Namaste, I am Dr. S.K. Wangnoo, working as Senior Consultant Endocrinologist at Indraprastha Hospital, New Delhi. Today I am going to discuss one interesting case. A 42-year-old male with a history of diabetes for the last 4 years, a known hypertensive control on ARBs, that is telmisartan 40 mg daily, a known history of hyperlipidemia or the dyslipidemia with a controlled lipid parameters on statin 10 mg daily. He was referred to our Department of Endocrinology because of his grossly uncontrolled blood sugar values. When he came to me, his HbA1c was 8.7 with a fasting blood sugar of 165. The lipid parameters were within the recommended normal values as per the patient's age. The blood pressure was okay, 130/80. The liver enzyme shows elevated transaminases, indicative of the non-alcoholic fatty liver disease because he was a teetotaler. So, with the background of taking only one drug called metformin, with the ideally recommended dose of 2 grams per day, in 4 years, he was not able to keep himself on the target HbA1c or 7. Now, before we start discussing this patient, let's see the patient profile. A young patient with a relatively short history of diabetes, uncontrolled, with the normal blood pressure on medication, with normal lipid parameter on medications, with history of sleep apnea on CPAP. So here, what we should recommend. First, we have to see what is our target of maintaining HbA1c. As per the current guidelines, if the patient is young with a short history of diabetes and without any associated major complications, our main target of HbA1c should be 7 or less than 7. I will keep my money on HbA1c anywhere between 6.5 to 7. So what are the options with us? Now, one of the important parameters to think about the choosing any additional anti-diabetic drug is underlying HbA1c. Number 2, underlying body weight. BMI was around 29.5. He's on the heavier side, obese side. The third important thing is that patient has hypertension and dyslipidemia, though controlled on medication. But sleep apnea still stands as a single important risk factor for the cardiovascular disease in a patient of diabetes who is obese. Apart from the diabetes, hypertension, dyslipidemia, and the obesity. Looking at the patient, I think a single drug or the monotherapy is not going to help this patient at all. We know diabetes is a progressive disorder. There has to be a proactive approach in managing diabetes. And ideally, the patient should have followed up with his doctor every 3 months to look into his HbA1c and to modify the drugs accordingly. Timely intervention initially with the aggressive treatment will benefit the patient in reducing the long-term metabolic complications. Well, we counsel the patient, we discuss the pros and cons of the various oral anti-diabetic drugs available. And ultimately, when we told him about the combination of a DPP4 inhibitor and SGLT2 inhibitor like linagliptin and empagliflozin, with the recent data in the literature showing both the cardio-renal protection and with the ability to lose weight and to maintain the HbA1c, the patient was agreed and was convinced to start the treatment what we advised. And we know, as per the current recommendation, any patient with the baseline HbA1c 1.5% above the targeted values, which is 7, in his case was 8.6, should be advised, should be recommended to start with a combination therapy. What we did, we started the patient on the combination of the linagliptin and SGLT2 on the ongoing background treatment of the metformin, what he has been taking. And we know, we told him that with the EMPA-REG data showing a solid 3-point MACE reduction in patient with type 2 diabetes, and with the linagliptin having a cardiovascular benefit profile, both with the Carolina and the Carmelina trial, the patient was really convinced with our discussion and counseling, and he started with the combination linagliptin and empagliflozin on a background therapy. Patient was asked to follow up after 3 months. To our surprise, the HbA1c from 8.7 fell down to 1.2 minus 8.7. Can you imagine a reduction of 1.2% of HbA1c in next 3 months because of the higher baseline value of the HbA1c? His BMI fell down by 1. It became 26.5. It was 28.5 by 2. And he was showing a lot of improvement in the feeling of day-to-day activities, physical stamina. And he was telling, I am a different person now. I lost weight, I improved my sugar. The fasting sugar was anywhere between 110, and the post-prandial sugar was hovering between 140 to maximum 165. We counsel the patient again not to stop this treatment because it has to be long-term treatment. And we told the patient to follow up after 6 months, and to our surprise, he was maintaining an HbA1c of less than 7%, which was our ideal target in this patient, and continued to lose weight another 1.5 kg. When we called the patient after 6 months, we were surprised to see this HbA1c was less than 7. He has lost weight further 1.5 kg, and he was feeling very well. Not only physically, emotionally, he was feeling that I am a different person now. So this is an example, real example, to show you the early intervention at a proper time, looking at the patient's characteristics, whether the patient is young, what you want to offer him in the long term. Because type 2 diabetes is a progressive disease, and any diabetic, even at the time of presentation, is having risk of developing cardiovascular complication. The risk is continuum. The continuum risk of the cardio-renal complications start from the day patient is diagnosed, even before the patient is diagnosed during this stage of insulin resistance. And the combination of gliptin and SGLT2 basically acts on the 6 defects of the pathogenesis of diabetes. They almost cover 6 fundamental underlying defects in the pathogenesis of type 2 diabetes. And not only the hardcore evidence regarding the cardio-renal protection for the long run will help the patient, young patient, to have a comfortable life free of complication, and he will be able to maintain his target HbA1c because we know the durability of this particular combination. So patient is again told to follow up once in 6 months, and we will see in near future how this follows. But the main idea, this is my last line, the purpose of this podcast to tell you about the early intervention with a combination which is proved beyond doubt with the hardcore evidence that it not only helps in the reduction in the 3-point MACE, but it also helps in the renal protection in terms of the progression of the albuminuria and the what you call the doubling of the serum creatinine. And this mechanism is because of the unique action of the SGLT2 on the renal tubules, which is through the renal tubular-glomerular feedback mechanism, improvement in the renal function, and the cardiac benefits are primarily because of the increase in the myocardial oxygen capacity, decreasing the apoptosis, and also influencing the sodium hydrogen ion exchange protein in the myocyte by modulating the intracellular calcium level. With this level, I think I am justified in telling that we should always look into what are the drugs we should consider looking at the patient profile to give him the maximum cardioprotection in the future years to come. Thank you very much.